we're going along.
Yeah.
If people are running a bit late. So hi everyone, thank you for joining us. So this is another session as part of the Inspiring ENT program, where we've had a lot of different talks from different universities and just a collaboration between all the different ENT societies across universities in the UK. So we've got today Professor Owen Judd, who is a consultant ear, nose and throat surgeon and associate medical director at the Royal Derby Hospital. He also works with the University of Nottingham as an associate clinical subdean, and has previously studied medicine at the University of Nottingham, graduating in 1998. So he's got an interesting career path that he's had. So I'll leave it with Professor Judd to introduce himself, and we'll get started from there. Thank you.
Hi everyone, it's good to you to join us this evening. So my remit was to look at what I can talk to you about that's interesting and new. And so I put together a talk on advances in ear surgery. So it's really how things are moving forwards with regard to how we do ear surgery and different methods of operating, and new things that are coming in all the time. So by the time you guys get to consultant level or even senior trainee level, things will have changed quite drastically, I expect. And some of the things that I'm talking about this evening, which only a few places do around the UK and indeed the world, it will be more mainstream, I expect, by the time you guys get to your sort of levels of higher surgical training. So I'm going to try and share my screen, and when I'm sharing it, I want you to just let me know that you can see it all okay. So I'll go to that. Can you see that presentation all right, everyone?
Yep, we can see that.
Fantastic.
Yes.
Good. So I'm going to talk about advances in ear surgery. So I work at Derby, which I found out today, interestingly, is the second largest trust in the UK, which I had absolutely no idea. And we've got the largest anaesthetic department and the largest orthopaedic department, doing the largest number of joint replacements of any trust in the UK, which I was interested to know. So we've actually got quite for saying it's the second largest trust in the UK, we're actually one of the smallest ENT departments in our particular hospital. So I work at the Royal Derby, and there are 7 of us currently. But then we have also merged with Burton Hospital, which is why we're the second largest trust now. And they have 5 consultants there. So technically there's about sort of 11 or 12 of us in total for the trust, but we are still a bit separate at present. So I'm going to talk about ear surgery. So the main content is going to be talking about what endoscopic ear surgery is, which is the new emerging field, how we use laser in ear surgery, and how we combine these approaches, which is something we're pioneering in Derby. And then a little bit about future, about other ideas. We've got things that we can start to use as time goes by, and things that you guys will probably be able to embrace as you go through your training and become more experienced. So why do we advocate endoscopic ear surgery? So endoscopic ear surgery probably started in its infancy around 20 years or so ago, primarily in Italy. Our 2 colleagues in Italy initially were doing wax removal, etc., endoscopically, because their microscopes broke, and they realised that actually you get a much more superior view with the endoscope than you do traditionally with the microscope or even an otoscope. And I'll show you these as we go along. I've got lots of videos to show you. And then it's just progressed from there. So my journey with endoscopic ear surgery started as an SHO, working with a colleague who had been out to Italy, seen a couple of cases done, and then brought the technique back and decided to start doing some wax removals using the endoscope. I did a few and we enjoyed it, and we had a bit of a laugh. And then when we became registrars, he sort of progressed it further. And as happens when you're a trainee, is you basically do what the boss does, and the boss tells you to do. So if the boss does it a particular way, that's the way you do it for that job, and then you move to a different job and you do it a different way. And the whole idea of surgical training is you get little tips and tricks from each different consultant you work with during your training, and you hone your own technique, which is usually a bit of a mismatch of lots of other people's ideas and how they do things. And that's traditionally how we all work. And then there are standard traditional approaches to certain operations, but always everybody that you work with, you'll always know that there are some individuals who like to push the boundaries and try new things. So working with my colleague, we brought endoscopic ear surgery in the UK, and we started to forge a bit of a movement, trying to convert everyone across to this way of operating, which is far superior, in my view, a bit biased, than the traditional routes. So traditional surgery involves big incisions, removal of lots of bone to get into the middle ear, which you'll understand as you go through your training, but we'll explain it as I go through. Now, with the endoscope, you can do this minimally invasively down the ear canal, essentially. So it's one of your natural orifice surgeries, so to speak, which most surgical specialties are moving across to now. You get a much better visual field with the endoscope than you do with the microscope, and I'll explain why in a moment. The magnification is actually better, so even if you've got your microscope on maximal magnification, you can actually see more with the endoscope than you can with the microscope. And I might have to flip out and show you a video of that at the end if you remind me. I've got videos of individual red blood cells flowing through the blood vessels, which you can see at magnification with the endoscope. So remind me at the end if I forget. You can see around corners. So traditionally with the microscope, you only see what's in front of you. And if you've got something blocking your view, like bone, you have to remove it in order to see what you want to see behind. Whereas with the endoscope, you can look around corners. I'll explain that. And of course, the equipment's much more less expensive, rather, than an operating microscope, and it's portable, of course, as well. So the main thing is minimally invasive. So this is your traditional ear surgical techniques. So the ear surgical techniques might be, for example, putting in a grommet. You might be looking down the ear canal using a light source, so a microscope or even an otoscope. But what you only see is that little section in front of you. So it says limited transcanal microscopic access, and that's the same view you get with the otoscope. So when you're looking with an otoscope, for those of you that have done that, you have to move the otoscope around and you have to move your head around to look around all parts of the eardrum, and that's one of the limitations. So in order to get better access to the middle ear space, you have to go through the mastoid bone from behind, which involves a big post-oral access, as it shows here. You have to remove lots of bone to get good access to the middle ear space. Using the endoscope, however, because the light comes out of the end of the endoscope, as opposed to the microscope, where the light comes from the microscope and has to travel through the ear canal, you get a much wider field of view. So to give you good examples of that, that is the edge of a tympanic perforation seen through a normal ear speculum looking down a microscope. Now, if I can just put my pointer on, let me just see if I can get the laser pointer. Can you see that on the screen, guys?
Yep, we can see that.
Right, so this is a speculum. So what we use in ear surgery is something called Tumarkin speculums, which are a little bit like the speculum you put on the end of an otoscope, except it's a bit larger, a bit like an ear trumpet, I suppose. And they have they're a certain type that have a split in them, meaning you can get instruments in and out easily. So we place the speculum in the ear and then we look down with a microscope. And you can see part of the tympanic membrane here, and you can see the edge of a perforation there. Can you all see that clearly? And that's the standard view that you would get with a microscope. Now, if you wanted to look at the same perforation with the endoscope, this is the view you get. And as you can see, it's significantly superior view. So there's the edge of the perforation you could see with the microscope. But with this view, you can see the whole of the perforation. In fact, you can see the whole of the eardrum. You can see all that slough there where it's been infected. So the view with the endoscope is significantly superior to the view with the microscope for simple things like this. And actually that extrapolates then to surgery. As you can see, the magnification is better as well. So when we're going for surgical view, you get a really clear view of very small discrete areas. So if you're aware the middle ear, is a space which is about 1 centimetre cubed in volume, so it's very small. So to orientate you on this picture, this patient's lying on their side. So this is the anterior tympanic membrane, the posterior would be here. So the tympanic membrane would be in this region here, where I'm drawing the circle with the laser pointer. And this patient's on their side, so you're looking at it side on. So here is the hand of the malleus coming down here. Okay. The incus would be here, and this is the head of the stapes. So this patient's on their side. So this is the anterior tympanic membrane here. The posterior tympanic membrane has been reflected upwards, so it's been lifted upwards like a hinge, basically. And you've got the middle ear here, it's behind the behind the tympanic membrane. So this is the promontory, the basal term of the cochlea. Now this patient's had cholesteatoma, so they've had it removed. So this is what we call an aticotomy. So we've opened up that top part of the ear canal, and I'm going to go through all of this with you in more detail shortly with some videos. And this is the head of the malleus. Now the incus here is missing because it's been eroded by the disease. This is the attic, and then that goes down there into the mastoid chamber. And then here we have the head of the stapes, the bone of hearing. And then this is the facial nerve here. We're going to go through that in a little bit more detail, but this is really just to show you an example of that magnification you get with the endoscope that you really miss out on with the microscope, plus that wide field of view all in one image. So what it also helps is much better view of normal. So you've all hopefully used an otoscope, or at least seen the sort of image you can get through an otoscope. But if you put an endoscope in the ear, this is the image you get. And I think you probably all agree that having used an otoscope and trying to get your head round and trying to see all bits of the eardrum is quite tricky. If you put an endoscope in, you can see it all in one image. So here's your normal healthy tympanic membrane, handle of the malleus. There's the middle ear structures beyond it. You can just about see the incus coming down here, and that's the chorda tympani running across the back of the tympanic membrane there. So you get a really lovely view there. Which also means if it gives you a better view of normal, it should also give you a better view of pathology. So this is a retracted tympanic membrane. So we're going to talk a little bit about retractions and then how the endoscope is really helpful when you get disease secondary to retractions. So as you know, the middle ear space is full of air. The air gets into that space through the eustachian tube. And then if you have problems with eustachian tube function, or you have problems with the mucosa of the middle ear and the mastoid chamber, you can end up with a vacuum essentially in your middle ear space. So the oxygen and nitrogen in that space gets absorbed by the mucosal lining, and you end up with a vacuum that sucks your eardrum inwards. So this is a pars tensor retraction. So you're aware of the pars tensor being the tight part of the drum. And you can see how that retraction has been sucked onto all the ossicles. So you can see the outline of all the ossicular chain clearly. And then here we've got what's known as the pars flaccida, which is the bit at the top of the eardrum. And that's getting sucked up into that space above the tympanic membrane, which is called the attic. Now, why do we get retractions? Well, we get retractions because of damage to the tympanic membrane, which makes it lose that normal fibrous layer. So we have two slightly different structures. So the pars tensor, the tight part of the eardrum, has lots of collagen fibers in it. It has lots of fibroblasts which produce collagen, and it's really well structured, the collagen in that area. So it's a nice tight part of your eardrum. The pars flaccida, by contrast, has much less collagen. It does have collagen in it, it does have a fibrous layer, but it's really sparse and haphazardly arranged. So it is inherently floppy, hence the term pars flaccida. However, if you get damage to your tympanic membrane, let's say, for example, you've had a grommet inserted as a child, or you've had a perforation due to infection, or you've got barotrauma, what happens is when the eardrum heals that perforation, it heals it really only with two layers. So you have an inherently weak part of the tympanic membrane. If you then subsequently have problems with middle ear pressure reducing, you will get suction effect, as is here, and you'll draw those areas of weakness in and cause retraction pockets. The way retraction pockets tend to occur is like this. So you see at the top there, you've got a normal healthy pars tensor, lots and lots of collagen fibers, lots of fibroblasts floating around which are able to produce more collagen. In the pars flaccida, it's more sparsely and haphazardly arranged, which basically means that the pars flaccida is essentially a little bit like the part of the tympanic membrane that could potentially form a retraction pocket, as you see at the bottom there. So just to orientate you again, this is the skin. So this is the outer layer of the tympanic membrane, and that's the middle ear mucosa. And then the fibrous layer is the organized layer in between. So if you get retraction pockets, what tends to happen is skin on the outer layer of your tympanic membrane, which normally is designed to migrate out of the ear canal and your ear cleans itself really effectively. If you have a retraction pocket, that skin as it's migrating will end up inside the pocket. So here, what we would have, so this is all skin lining the external ear and the outer layer of your tympanic membrane. If those skin cells migrate normally, what would happen is they start from the central part of the tympanic membrane and then migrate outwards in a radial pattern, a little bit like a clock face. So those skin cells migrating downwards would migrate to the bottom, and then they would start to migrate along the ear canal skin till they reach the outer third of the ear canal, which is where the hair-bearing skin is and the ceruminous glands producing that thin oily fluid called cerumen. And when the dead skin cells get mixed up with that cerumen, that's essentially what earwax is. So your ear cleans itself really effectively. If, however, you've got a retraction pocket, and here what's happened is the middle ear space has a negative pressure within it because the eustachian tube is not functioning properly. It sucks the pars flaccida, inherently floppy part of your eardrum, into this space. It then causes a retraction pocket. Now, this is the ceiling of your ear canal, and if you can carry that imaginary line across the ceiling, across that middle ear space, anything that's above that imaginary line is above the ceiling, so we call that the attic. So this is the attic, the medical or anatomical term for epitympanum. So what happens is your pars flaccida will get sucked up into that space, so sucked into the attic, you'll have an attic retraction. And then your dead skin cells will start to, as they migrate, will start to collect in that pocket. So you can see here, the pocket's collecting dead skin cells. And of course, what then happens is this process remains unchecked. So that repeated negative pressure in the middle ear space keeps sucking on behind that pocket and pulling it in further. So it's being pulled in deeper here. You have more skin cells dead skin cells migrating out all the time, but they'll end up inside that pocket. And then eventually what will happen is you'll have this huge mass of essentially dead skin cells. Now, dead cells undergo necrosis, so they undergo apoptosis. They want to start breaking themselves and the surrounding cells down by releasing enzymes. And that necrotic mass of tissue releasing enzymes will also start to break down surrounding structures. So it will start to break through the pocket and it will start to eat away at anything in its path. So it'll eat through ossicular bones, it'll eat into the bone that overlies the facial nerve, it will open up into any space and go into the mastoid, for example. And that condition, of course, is cholesteatoma. So cholesteatoma is when you have negative middle ear pressure, creating retraction pockets. You get those dead skin cells accumulating in those pockets, and that necrotic mass of dead skin is cholesteatoma. Now, of course, dead skin and necrotic tissue doesn't have a nerve supply, but dead skin also gets infected when it's exposed to the outside world. So cholesteatoma will always tend to present with a discharging ear, but generally speaking, a painless discharging ear because necrotic tissue doesn't have a nerve supply. And it will erode through the middle ear structures and bone. So the rest of the talk really is going to be talking about how we utilize those newer techniques, so endoscopic ear surgery, for example, endoscopic approaches to tackle cholesteatoma and the advantages that has over the traditional open surgical techniques. So when we see a cholesteatoma, this is the sort of thing we see. So on this one here, you'll see this tympanic membrane is retracted. So we've got retraction of this part here, the tympanic membrane. But you'll see this area here, and this is the tip of the cholesteatoma. It's sort of a fluffy white, and then it oxidizes in the air. So it almost looks a bit like wax. This one here is eroded through. So this here is the tip of the cholesteatoma, and you can see this large necrotic mass of tissue here. In this image on the left, what's happened is this cholesteatoma is actually eroded through this bit of bone here. So this bit of bone is what we call the scutum. So it's a shield of bone that protects the attic from the ear canal. It's the upper part of the ear canal, really. So what happens in this situation is that cholesteatoma has gone in, it's eroded through this bone and come back out into the ear canal. So you can see here it's opened up that space. And this is what we call an autoatecotomy. So the patient has done their own surgical approach by opening up that bone there. By the disease itself is eroded through that bone. But what cholesteatoma tends to do, it doesn't always do this, but often it will it will erode that bone as time goes by, but it always tends to go backwards into the space that is directly behind the middle ear, which is the mastoid space, which sits in this area here. So you can see here the cholesteatoma is wrapping itself around the ossicular chain, and it's extending backwards, and it's starting to move into the mastoid bone here. So cholesteatoma is a very slow growing process, so it takes a few years to get to this level. But it eats through anything in its path. It eats through nerve, bone, cartilage, and it's very, very destructive locally, but it's not malignancy. So it doesn't happen rapidly, and it's not malignancy in that it doesn't spread elsewhere, it doesn't metastasize, but it is locally very destructive disease. And of course, potentially it's fatal if it's not treated, because the roof of the middle ear space here is this very thin plate of bone called the tegmen, and the other side of that is the temporal lobe. So it will quite happily erode through that and exposing patches of dura, which ultimately could then lead on to central infection, meningitis, and cerebral abscesses, which of course, if they rupture, kills you. So ultimately, if you do nothing about cholesteatoma, it is a fatal disease. But hopefully we never want it to get to that stage, and that's why we tend to operate. So here's a case of cholesteatoma seen with the endoscope, as you can see. So we have a relatively normal, healthy-looking tympanic membrane, but at the top we have this crust which looks at first glance like wax, but it seems to be going inwards. And this isn't wax, this is actually oxidized cholesteatoma, so dried out cholesteatoma. So what we'd first do is we would clear all of that debris out. And when we clear it out, you can see that this area has retracted inwards, that the bones are exposed, and then you've got disease going around the corners. So the traditional route of operating on this would be to open all of this area up, and this goes back into the mastoid bone behind the ear. So you would need to open up the mastoid bone and essentially remove this part here. So if the cholesteatoma, if you can imagine, is going in here, it's going behind the canal wall. If you can imagine looking at my ear, it's going behind the canal wall and it's going backwards into the mastoid. So it's going backwards into this space here, which sits behind the middle ear. So a traditional approach would be to remove this posterior ear canal wall to expose the mastoid chamber. And what happens is you end up with what we call a mastoid cavity, which looks like this. So this is your traditional open mastoid cavity. So you can see the tympanic membrane there. You can see where the cholesteatoma has gone in, but then it has also gone back into the mastoid. So you have to open all this up, clear it all out, and then reline it with grafting material. Now this has ups and downs. So the downside of this is this patient can never get their ear wet again. So if this patient goes swimming, what will happen is you'll get water sequestering in this little chamber here, and that will become infected and they'll have a discharging cavity. The other downside is because you haven't got a normal ear canal, what will happen is skin cells won't migrate out normally anymore. So they'll start to build up. And so you'll start to get wax build up within the ear. And these patients need lifelong ear cleaning. So they need to come back usually to our nurse-led clinics once every 3 to 4 months or so and have their ears cleaned out because they don't no longer clean themselves. So those are the downsides of this type of approach. The upsides, though, is as you can see straight into this, and you can see into it with a normal otoscope. So if you have a little patch of recurrent cholesteatoma in an area within the cavity, you can see it. It will discharge, so it will declare itself early, and you can fish it out with the patient awake. But the downside is that you've got an ear that you can never get wet, and you've got an ear that often the hearing is not quite normal, you've got abnormal anatomy, and you have an ear that doesn't clean itself anymore. Plus, you need to do a post-oral approach, so involves quite a big incision. Also, it tends to end up with us opening up the ear canal, so you have a much wider ear canal, what we call a meataloplasty, meaning you can get better access. So cosmetically, it's not great, and functionally, it's not great. So we need to move away from that, really. So we want to move away from this sort of facility where you've got a big open cavity and an ear canal, which is the posterior wall of the ear canal has gone, to this sort of picture, where you have a normal ear canal, and where the cholesteatoma was is removed and it's been repaired with a piece of cartilage. So what I'm going to do now is I'm going to go through some videos of surgical treatment using the endoscope. So one of the first few cases I did of endoscopic cholesteatoma removal, and we'll go through it step by step. But before we go any further, have we got any questions?
I don't see any hands up or anything in the chat.
Good. So we'll carry on, and we'll have questions at the end. So first of all, so this is the patient lying on their side. Let me just see if I can turn this off. So we've got the patient lying on their side here, and we go in with the endoscope, and you can see that image that we saw right at the beginning. So the patient's side on, they're lying down. So you've got the handle of the malleus, you can see just where I've touched there, and you can see that opening at the top into the attic region. So you can clearly see that the cholesteatoma's caused a lot of damage there, and it's eroded backwards. So the first part of the surgery is to lift up the tympanic membrane to inspect the middle ear space, and then to allow you then to open up downwards into the mastoid to see what's going on. So we make an incision first of all, and then sort of I tell the trainees a little bit like lifting up the toilet seat. So what we're doing is we're making the incision so we can lift up that toilet seat. Essentially, we're lifting the eardrum, we're folding it forwards. So that's sort of the initial incision that we would make. And then you can see there I'm lifting the eardrum forwards and peeling off the bone. So this is the bone of the ear canal at the bottom there that I'm lifting that tissue off. And you can already see that the edge of the bone looks very sharp, so it's already been eroded by the disease. Normal non-eroded bone is much smoother than that. And then I'm now starting to remove pieces of cholesteatoma bit by bit so I can see what's going on. Now again, I don't know whether I can put my pointer on at the same time as, yeah, I can. So this is the chorda tympani. So this is the nerve of taste here. You've got the back of your eardrum here. That's a little bit of cholesteatoma coming out. That's up into the attic space there. And then this here is the head of the stapes bone, and that's stapedius tendon. And this is the middle ear space, so that's the promontory. I can, fortunately, when I've got the pointer on, I can't play the video at the same time. That's annoying. Okay, so what I'm doing now is I'm delineating. So we've got the head of the stapes on the left, and where my instrument is there, that should be where the long process of the incus is attaching to the top of the stapes, and it's missing. So you can see it's missing there, and you can see the chorda tympani is the nerve that runs right across the center. So that is a branch of the facial nerve that supplies taste to the tongue. So I'm using these scissors now to cut through the little fibrous band that's left of what was once the incus. So the long process of the incus, okay, I'll put the pointer on to show you this. The incus should be here, and in fact some of it is still there, and you'll see me remove it shortly. But there should be a long process of the incus that comes down here and attaches onto the top of the stapes, and you can see that's gone. We've only got this little nubbin of it here, and that's because this cholesteatoma has eroded it away. The stapes, however, looks intact. There's the top of the stapes, stapedius tendon here. So that will be the oval window there that the stapes is sat within. And then this is the nerve of taste. This is your chorda tympani nerve. So we'll move on and go to the next slide. So now what you see is I've got a little bit more exposed, and I'm going to take the bulk of the cholesteatoma out now. So you'll see how one of the advantages of this technique is I can see everything in front of me, so I can get this huge big piece of cholesteatoma out very safely, because I know I'm not touching anything else, because I can see my entire field of view. The problem with doing these procedures with the microscope is you can literally only see what is in front of you. So as you saw on that view of the tympanic perforation, the difference, if I was using a microscope for this, I would only be able to see this part here. I wouldn't be able to see any of this. So as I'm removing this bit of tissue, I wouldn't know how close I am to the stapes or how close I am to the facial nerve, which sits under here, or the chorda tympani. So it's much easier to damage tissue unless you're entirely aware of exactly where you are at all times. Whereas with the endoscope, you can see where you are at all times. So it's actually a much safer approach. We're removing a little bit more cholesteatoma there. The other advantage is you can use angled telescopes, which means you can see around a corner. So most of the scopes that we've got, so the one I was using up to now, look straight out of the end of the telescope. But what you can use with endoscopes is ones that have angled ends to them. So they have mirrors and they have prisms within them, so you can actually see around a corner. So I'm using an angled telescope now to look into the cavity and actually look down and essentially round the corner into the mastoid. And you can see here on the right that there's still cholesteatome within that mastoid, but there's nothing in the middle ear space. So I clearly need to remove a little bit more. So now after removing that, I'm going in. First of all, you can see this wound here, and I'll talk to you about that in a moment. But now you can see with that angled telescope that all of the disease has gone. And you can look right around the corner, right down into the mastoid tip there on the far right-hand corner of the screen. The lower right-hand corner of the screen. So we'll play that video again so you can see that. So we go in with the angle scope, so it's a 30-degree angle scope, seeing 30 degrees around the corner. And that allows me then to look around that, and you can see I can go right down into the mastoid tip with that. Now, the only way to do that with the microscope would be to remove all of that bone that's in front of it. So if I wanted to look down there with the microscope, I would have had to remove all of this bone here to get down there, because I can only see what's right in front of me with the microscope. I still use the microscope frequently, but my preferred method is now the endoscope, just because it's much more superior. So basically, we've gone from that to that open approach that you saw there, so that we then can open everything up and see into the space where the cholesteatoma was and remove it. So you can see it's minimally invasive. You haven't got a big open cavity so far. But of course, what we do have to do is reconstruct it. So where we've got this space on the right-hand side and we've opened all of that up, we now need to be able to close over that bone to repair that defect. And we can use cartilage in this sense to close over that defect where the disease has eroded the bone, or we've had to remove a small ounce of bone to get around the corner. And so what I tend to do is use cartilage from the tragus, make a little incision just in front of the tragus, so there's no cuts on the outside of the face at all with the endoscopic ear surgery, and take a small piece of the cartilage from the tragus and place that as a graft. So that's now my graft, which is placed just over the that defect that has been caused by the disease, and also widened a little bit for access. So you can see the cartilage graft here. And I've also put another small piece of cartilage over the head of the stapes. And when the new eardrum sits on top of that, that will essentially act as a new incus, as a new ossicular chain. And it can help restore hearing in the vibratory component of the tympanic membrane and the ossicular chain. So what we do is, when we take the tragal cartilage, we also take a layer of the perichondrium that sits over the top of the tragal cartilage. So just before we remove the cartilage itself, I peel perichondrium off that. And then this is me putting the perichondrium in. Now you'll see that what it seems to do is it seems to sort of stick itself to the instrument, and that's one of the downsides. So one of the difficulties and the downsides of endoscopic ear surgery is all of this surgery you've seen is all single-handed. So I'm only using my right hand to operate, because the left hand is holding the camera all the time. So I've got the endoscope in my left hand, and you have to operate with single-handedly. So unlike with the microscope, where you can use instrument in either hand and have two hands, Endoscopic ear surgery is more difficult to get to grips with and to master because it's single-handed surgery, but it's something that you can do quite easily with practice. But one of the challenges is that you, just like this, as you can see on this image, when you're doing something with a single hand, you can't manipulate things with another hand. So I can't use another instrument to push that off the end of that little pair of forceps. So if grafts or instruments stick, you just have to manipulate them until you can get the graft in place. And then what you'll see now is I'm using that piece of perichondrium as the new eardrum, basically. So I've got that cartilage in place, which will help to reconstruct that defect in the bone at the top. And we're using the perichondrium there to create a new eardrum. So you can see there, and that will be the new eardrum when everything is healed. So we've gone from that image where you've got that defect at the top caused by the disease. Now, as you saw in that video, I've had to remove this little bit of bone here, just that small amount, to get access, but not all of this bone as you would have to with a microscope access. And then when we've repaired it with cartilage, this is what you get at the end. So that area now is then repaired with cartilage. So essentially you've got a normal anatomical ear canal, which means that it can get wet without a problem. Patients can still go swimming. The ear will clean itself because you haven't interrupted the integrity of the ear canal, so the skin will still migrate out normally. So you don't have to have lifelong follow-up for cleaning. But the downside of this approach is you can't see if cholesteatoma is reforming behind that repair. So the only real way, traditionally, to have a look behind that repair to see if there's any cholesteatoma coming back would be to do a second look operation at a year down the line to check that there's no recurrence. But now, along with the endoscopic approach, we also have new MRI sequences, so what's known as non-epiplanar diffusion weighted imaging, that allows us to pick up whether there's any signs of recurrent or residual cholesteatoma behind our repair. So we don't have to operate on everybody just to check anymore. So things are improving and advancing all the time. So as you probably remember from the beginning of this talk, one of the reasons we developed cholesteatoma in the first place is because of retraction pockets. But the question then that I always used to ask is, well, why don't we treat the retraction pockets so that they don't end up forming a cholesteatoma? And of course, one of the main questions in ENT is to do with the eustachian tube itself. If you could fix the eustachian tube, you wouldn't have problems that form like glue ear, for example, so a trisomy with effusion. You wouldn't have problems with retraction pockets or cholesteatoma forming. But there's lots of things people have tried with the eustachian tube, and it's such a complex bit of anatomy, partly bony, partly cartilaginous, partly muscular, partly mucosal, that there's not one be-all and end-all fix for the eustachian tube. So most of ear surgery from point of view of disease these days tends to rely on managing the disease that forms as a result of those problems. So my question was, how do we actually treat retraction pockets? Is there anything we can do that would prevent a retraction pocket from getting deeper? It would reverse the process and potentially therefore limit the chances of cholesteatoma forming. Which brings us on to the last part of the talk, which is about more novel techniques. You can see on this video, you have this retraction pocket. So this patient's got that retraction pocket in the posterior part of the tympanic membrane. But when they blow their cheeks out, when they do a Valsalva maneuver, the pocket pops outwards. So it's a mobile pocket, it lateralizes, meaning that it hasn't got to that stage where it's stuck down and skin cells will start to migrate inwards. So these are the sort of retraction pockets that are at the ideal position for us to be able to treat these. So ideally, what we want to do is prevent the process of cholesteatoma forming. So traditionally, you can do things with the retraction pockets if they're problematic. You can cut them out, leaving a hole, and then graft the hole. Or some people have even tried using ventilation tubes. So you bypass the eustachian tube being obstructed by putting a grommet in, so a ventilation tube. But what studies have shown is actually that doesn't prevent the retraction pocket from reforming when the grommet comes out. And actually, there's no evidence that putting a grommet in actually will prevent retraction pockets from progressing as the time goes by. So we invented, I suppose, a couple of newer techniques to manage retraction pockets. So something called a glue tympanoplasty, which we came up with one day with one of our registrars, and a laser tympanoplasty, which is something that we're doing quite a lot of. So we'll run through these two novel techniques. So glue tympanoplasty. So here you can see a retraction pocket. So this retraction pocket is an anterior pocket. It's gone quite deep. So there's a chance that as the skin cells start to migrate, they'll migrate into this pocket and form a cholesteatoma. But this pocket was still mobile. So if you placed a sucker on this pocket, you could pull it out like a plastic bag, and you'd have this big baggy area of tympanic membrane. Traditionally, what you'd have to do is cut that away, leaving a hole, and then graft the area, which of course then never really vibrates like a proper eardrum. So what we did is we devised a technique where we pull that out, pull the pocket out, and then glue it flat onto the tympanic membrane. So here you can see the pocket pulled out, and then it's pulled down and it's flattened onto the tympanic membrane and glued down with tissue glue. And you can see that there. You see that when it's been glued down. So we just, and this, again, this video really just shows you that edge of the pocket having pulled it out. So we reverse the pocket essentially, and then gluing it on the surface of the eardrum. And then we wanted to follow this patient up to see if that was effective or not. Because of course, if it's not, if it doesn't work, we've not really lost anything. It was a minimally invasive procedure, and we can always revert to the standard approach of just cutting the pocket away and grafting it. But to our surprise, it was very effective. And this was before, and this was 12 months later. And you can see it's not really recurred, and it's still nice and flat. In actual fact, I saw this patient only a few months ago at 5 years post-surgical intervention, and it looks exactly the same. These white patches you can see on the tympanic membrane here were here initially, but they're much more pronounced now because this is tympanosclerosis. So this is just slow, progressive calcium deposits within the tympanic membrane, or scarring, if you like. But the pocket has essentially sorted itself out, which is great, and it's healed down when we use tissue glue, and it's not recurred. So are there any other techniques? Well, yeah, we can use laser. So what is laser? Laser is an acronym for those that didn't know, and it stands for light amplification by stimulation of emission of radiation. So basically what you do is you shine light through a medium, and the medium concentrates that light, and it stimulates further emissions, which emits that radiation. And depending which medium you shine the light through, or you target your electrons through rather, you will get different coloured lights of a different spectrum. So it uses the normal, visible, and the ultraviolet and infrared spectrum. And the way that laser works when we're talking about surgical treatment, but also in industry as well, is it's essentially, because it's such concentrated energy and concentrated light, it generates a lot of heat. It can also ablate through tissue depending on the wavelength, and it will generally be absorbed by a tissue that is the opposite colour to the colour of the laser. So in this type of ear surgery, we use something called a KTP, which stands for potassium titanyl phosphate laser. And that has a very short wavelength. It's 532 to 585 nanometers. And it's a bright green laser light. So it tends to get absorbed by a colour that's diametrically opposite it on the colour wheel, if you can remember the colour wheel from school. So it tends to, a KTP laser, which is green, tends to primarily get absorbed by red pigment. So it's really good laser for vascular lesions, and I'll show you a video of us removing a vascular lesion a bit later on. And it gets absorbed maximally by red pigment, so it's picked up by hemoglobin. So it's really good, for example, in aesthetics, to treat thread veins and spider veins on the face and redness, because it gets absorbed by the hemoglobin, causing heat dissipation. So if you remember this slide from earlier on, you have your normal tympanic membrane pars tensor at the top and the pars fascia in the middle, but then that retraction pocket, the problem you've got there is you've got few fibroblasts, few collagen fibers, and the collagen fibers are weak and haphazardly arranged. So ideally, what you want to do is you want to cause those collagen fibers to contract, to tighten up the tympanic membrane, and you want to stimulate production of more fibroblasts that will stimulate production of more collagen to then make your repair more robust. So what laser does, and this is something I stole from the aesthetics industry, is the way laser works is it heats up tissue. And that's how it works for facial rejuvenation, for example. It heats up the tissue, which causes the collagen fibers to contract. And as the collagen fibers to contract, they create tightening of that retraction pocket, causing flattening of the tympanic membrane, and the pocket will tighten. But then the heat will also cause further fibroblasts to form, stimulate more collagen production, and over a short period of time, we think about a week or so after the surgery, you end up with tightening of your tympanic membrane, but also reformation of that collagen network, and so it becomes more of a long-term solution. So here is a patient with a retraction pocket. So this patient's got an anterior retraction pocket, you can see here, and this retraction is really quite mobile. It comes in and out as the patient breathes. So what we're going to do, I'm going to show you some videos now of me lasering that pocket and then the final result. Now, just before we go to that, what I will tell you is here at the back, so this isn't the only pathology in this patient. This patient has this retraction pocket at the front, but you probably notice they also have this defect here, and they have this unusual white mass here behind the posterior part of the tympanic membrane, and this was cholesteatoma. So this cholesteatoma had gone in through here, and it had caused a disease process in this area here, which I have to deal with as part of this surgery as well. But I'm just going to show you the laser tympanoplasty part of this. So now I'm going to warn you now that you will get some bright flashes on the screen, just in case any of you are light sensitive. But you can see that's the guiding beam, which is always red. And then the laser, as I said, the KTP laser is a bright green light. So it's 532 nanometers, so very short wavelength. So it's visible light laser, and it's bright green. So as you can see, each time I fire this onto the drum, can you see how the drum tightens? Visibly before your eyes, it gets a little bit tighter each time. And so what we're doing now, we're using, so this was one of my first few cases of this technique, but what we're doing now is we're using a mode called super pulse on the laser. So instead of individual single shots, it fires about 10 shots in very short succession in one area. So you can see it's slowly heating up each area as we go, and you can see that drum tightening. Can you see how it's not as mobile now as it was right at the beginning of the procedure? So now when I've applied the suction to that drum, you see how it's much tighter now at the front compared to what it was like at the beginning of the procedure. So it's tightened up nicely. And this is what it's like at 12 months. So you can see now, 12 months down the line, how the anterior tympanic membrane looks essentially normal. It looks nice and tight in comparison to how it was. The posterior tympanic membrane, for those of you who've got keen eyes, will notice that it looks abnormal. And this is a cartilage graft that we've used to reconstruct the back part of the tympanic membrane, which was where the cholesteatoma was that you saw earlier on. So this is what it looked like at 12 months. And this is what it looks like at 24 months. So it's maintained, and it's a long-term result. So this was previously, so before the surgery. You can see the retraction pocket anteriorly, and this is the nice, tight, essentially normal tympanic membrane anteriorly at 24 months post-surgery. And we're still monitoring these, and our first few cases are now getting to about 5 years down the line, and so far they're all still absolutely fine with no clear signs of retraction pockets reforming. So it's looking like a very promising technique. So when we're talking about novel techniques and things that are used more now than weren't used when I was a trainee, so again, sort of advances in ear surgery, the laser is also being used in lots of other ways as well. So the laser tympanoplasty is the most novel currently. But the laser can also be used for stapedectomy procedures, so to replace the stapes in a condition called otosclerosis. So it's used to remove parts of the stapes and help to place a prosthesis. It can actually be used for cholesteatoma itself. So what I'm doing now is combining endoscopic ear surgery for cholesteatoma and laser surgery together to not only treat retraction pockets, but also to actually treat cholesteatoma itself. So if you fire the laser at cholesteatoma, either the carbon dioxide laser, which has a much wider and longer wavelength, or the KTP, which you just saw, what it does is it vaporizes and coagulates at the same time. So it will vaporize cholesteatoma and essentially burn it away from the tissue. So it's quite good to remove little patches of cholesteatoma that might be stuck on the dura, for example, and avoid exposing the brain if it's been eroded away, or on the ossicular chain if you can then help to maintain the ossicular chain continuity. And it can also be used for vascular lesions. So we've got a video now which shows you an endoscopic view of the ear. Don't know whether you can hear the sound there. This is a colleague narrating a video that we did.
On the eardrum, you can see the bones of the middle ear, malleus, and the incus. You can just see behind the eardrum. This is a picture of an eardrum and is pulsating and red because there is a tumour behind it.
This is a middle ear vascular tumour.
By lasering it, which results in it shrinking down to finally be removed.
And you can see there the KTP laser is used to, and you can see the tumour shrinking away.
You can see it is gradually shrinking away.
So that's a good example there of combining the laser with an endoscopic approach.
This is a camera.
So where do we go from here? What other things do we have in the future that can help to improve our surgical techniques even more? Well, micro instrumentation is coming to its fore at present. So one of the things that we're trialing at present is use of micro endoscopes. So endoscopes that are really small. So we're talking about 1 to 2 millimeters in diameter that can then go through the eustachian tube. So what I'm hoping to do as time goes by is not only use these small endoscopes to look behind the ossicular chain, which is where our ventilation pathways go, which is why we get problems with just isolated attic retractions, for example, but also to be able to get laser in areas of the ear where you can't currently get them, even with the endoscope, by being able to manipulate behind structures. And ultimately, what I'd like to be able to do would be able to perform middle ear surgery for patients who have problems with ventilation, but also have middle ear disease, without actually having to go through the ear at all, but actually go through the nose. So to use micro endoscopes and instrumentation to go through the nose, through the opening of the eustachian tube in the postnasal space and into the ear from behind, to take away problems within the ear without disrupting the tympanic membrane or the ossicular chain. So you can then sort all those sort of issues out within the middle ear without actually all the disruptive process of the surgical intervention, because of course we have to lift up an eardrum to get into the middle ear, and it never quite heals and never quite vibrates normally again afterwards. And there are colleagues, particularly in Europe currently, who are using a robotic approach. So we use robots a lot in surgery at present, and quite a lot in head and neck surgery within ENT. But no one's really using it in the ear at present. And that's mainly because the instrumentation that is used is too large to actually use it in the ear. And if you did, you'd have to revert to the post-oral approach and take a lot of bone away to get access. But as time goes by, these instruments are getting smaller and smaller and smaller, and we're able to start using robotic surgery. So currently, from an ear surgical perspective, the only robots that are currently being used are used to insert the implant electrode array for cochlear implants. So normal traditional post-oral approach, drilling out an area of the bone to get access to the middle ear from behind without lifting the tympanic membrane up, opening up the round window of the cochlea, But then instead of feeding the cochlear implant electrode array into the cochlea by hand, a robot arm would then do that, which means it's smoother, it's softer, it's slower and more controlled. But we expect as time goes by that robots will take over more and more some of the work, fine work we can do within the ear, because our hands are only as fine as each individual is. If you have a tremor, it's significantly exaggerated through a microscope or an endoscope. Whereas, of course, robots can be completely static and very still and slow moving. So much more controlled as time goes by. So that's the end of the talk. So we've talked about endoscopic ear surgery, which is certainly an emerging technology, and more people all the time are using this technique. How we can use laser within the ear and combine those two approaches, and some even more novel techniques that are coming as the time goes by. Thank you very much. Are there any questions?
Thank you very much, Professor Judd. I had a few questions, but one was in terms of the cholesteromas. Yeah, I know you mentioned the disease, just having them have that collection in the roof and then eating away at some things like the incus and looking at the mastoid bone. But I haven't really heard anything much about like I guess the disease process, or what is that reaction that's causing that erosion in a sense. I'm not sure if that's something that people look into and how the skin collection.
So we know the reason that cholesteatoma forms is because you get essentially ingrown skin. I mean, we learn these really complex definitions of keratinizing squamous epithelium migrating into the middle ear, for example, which is essentially what it is, but it's essentially ingrowing skin at the end of the day. You've got a retraction pocket, the skin's migrating inwards, and that's what happens. Again, like yourself, I thought, are there techniques, is there anything out there that can prevent cholesteatoma from forming? Is there medication, for example? But currently nothing exists like that. Even if you look at dermatology about medications and techniques to help to get rid of dead skin cells, you can't use those in the ear because they're cochlear toxic. So if you bathe the ear in that area, hoping that it will essentially dissolve away the cholesteatoma, sadly, it will also dissolve away the hair cells in the cochlea as well, and you'll lose your hearing. So at present, there is no alternative treatment for cholesteatoma other than surgical treatment. So from a purely selfish point of view, for those of you on the call, obviously you're all interested in ENT. If you want to secure a role in ENT for the future, become otologists. Because head and neck surgery is being taken over by robots, and also, of course, by oncologists with ever improving chemo and radiotherapy techniques. Nasal surgery is improving all the time with good allergy treatment, steroid delivery, etc. So ear surgery currently, particularly cholesteatoma, is the only one where you have no other alternatives. No one can take our job away from us at present.
Yeah. And in terms of the frequency of those, like say in practice in a year, how many of those cases would kind of come across to have to deal with?
So that's an interesting question. So cholesteatoma within ENT practice is very common. I probably see about 3 or 4, maybe even more than that a month. So it's actually really quite common. That's just an individual practicing consultant. Having said that, in the community, it's very rare. So I gave a talk to some GPs about 2 or 3 weeks ago, and one of the senior GPs said he'd only ever seen one cholesteatoma in his entire career. So it's a rare condition, but of course, by virtue of the fact that you're in a single specialty, and usually within that specialty, you'll have consultant colleagues that all have subspecialty interests. If you take most of the complex ear disease, you'll see nothing but cholesteatoma. So it sort of slightly skews your opinion on how common a condition is when all you ever see is that condition. But generally, it is rare overall.
Okay.
I have a question, if that's all right.
Yeah.
Hi, I'm Fenella. Nice to meet you.
Hi, Fenella.
So firstly, thank you for your talk. That was really interesting. I suppose so. My first question is for the mastoid cavities. So I understand that a lot of your approaches are trying to move away from that. But I actually just wondered, because that's the only skin that migrates in that way, doesn't it?
It is, yeah.
I wondered if there was any sort of developments about being able to graft that sort of skin, whether there's any potential for being able to grow that sort of skin in a lab and be able to use that to reconstruct the ear. Do you think there's any future in that?
Yeah, and in fact we do use fake skin, not quite the right word, is it? But we do use allografts and xenografts quite frequently in ear surgery. So only today I did a revision cholesteatoma on a child where I needed quite a large portion of tissue to cover over bone, exposed bone, because they'd had a previous mastoid cavity. Ultimately, I'm going to try and obliterate the cavity and reconstruct the canal wall. But for the first sitting, I need to try and reline the current cavity that he has. And there's just not really enough tissue for me to be able to do that, to graft over that area and cover all the bone. So we use a material which is actually made from pig intestine, so the submucosa of a pig's small intestine, and it's decellularized. So it's treated so that essentially all the pig cells are removed, and all you've got essentially is a meshwork of collagen fibers that have no cells within them. So it's a very safe material to use, and it's been these materials often have gone through rigorous processes. They're, I said, decellularized. They're checked to make sure they're safe and they've got no other forms of microorganism within them. And then they also go through a large legal process. So although it is initially from the pig, because it's decellularized, for example, it's approved by the Jewish Council and it's approved by the Muslim Council. So, and you've got to think about all these things when you're utilizing these sort of graft materials. But that's a really good example of where you can use essentially fake tissue to mimic tissue, and it works as a scaffold to allow the new skin to grow into that tissue and to cover over the bone.
And the
so
new
yeah,
skin
so we do use those sort of things.
The new skin that grows, will that be the same sort of tissue that where the cells migrate in that way?
It will, yeah, absolutely. But of course, if you've got a cavity, there's only so far it can migrate, and it will re-epithelialize that cavity. And that's where we want to eventually get to, is a cavity that, like that one that I showed you at the beginning, where you have that cavity, but it's all nice and smoothly lined with skin. So it's much easier to keep clean.
Yeah.
Whereas one of the problems we have with mastoid cavities, because it's an open cavity, if it gets moist, it gets infected, then it becomes very granular and sloughy, and then it just repeatedly gets infected and discharges. And then those patients need to have revision surgery to strip it all out and to reline it again. Right. So if we can get away from creating a cavity in the first place, we create lots and lots of benefit from the patients not having to keep coming back so regularly, and also not to have to repeat having further surgery.
Great, thank you. I had another question if there's time.
Yeah.
So this one's just to do with the endoscopic approach. I wondered how that technique might be able to change ear surgery in lower income countries. I wondered if there was a big difference in the cost of, say, a microscope compared to an endoscope, and the techniques needed to use both.
Yeah, absolutely. Yeah, well spotted that. And actually, that is exactly what is happening. So we run an ear camp in Nepal, which traditionally we always used to use old, essentially defunct microscopes from the NHS a lot of the time that have been sent out there rather than completely condemned. But you're right, they're big, they're bulky, they're expensive. So to buy a new operating microscope costs anything from 70,000 to 180,000, depending on whether it's got all the bells and whistles. Whereas an endoscope, you can pick up a decent endoscope and its appropriate light source for about £3,000. And the way a lot of the endoscopes work is they have a camera built into them on the end. But the traditional endoscopes we originally used to start using are literally just a tube that carries light down it and has lenses for magnification, and you can just look down the lens. I'm sure you've probably seen those sort of scopes that we can sometimes use. So one of those scopes plus a light source, you don't need a camera system. So the camera system might cost £10,000 or £12,000, but you don't need one realistically. So if you're in an area where you haven't got electricity, you haven't got any areas or minimal electricity, you don't have the option of carting loads of big, heavy pieces of equipment around, such as in developing countries. You can go to the middle of nowhere with an endoscope and a light source and a bag of instruments, and you can do your ear surgery.
Yeah, that's amazing. That could be, yeah, bring about some really good changes.
Absolutely.
I went on my elective, I went to an ear clinic, and they had this amazing, really expensive microscope that had been sitting in the corner for 2 years because they couldn't afford to change the bulb.
Exactly, you see, and you don't need that if you've got an endoscope and a light source. You don't even need to buy that expensive microscope in the first place. You can use the same amount of money to buy 20 endoscopes.
I think Hassan, you had your hand up.
Yeah, hello. So my name is Hassan. First of all, thank you very much for the interesting topic and interesting procedures as well. My question is about, actually, after hearing what you said, I thought most important thing is to catch the disease early.
Yeah.
So is there any screening protocol or guidelines for the GPs placed so we can benefit from the glue or the laser therapy? Like, because I think they will do a revolution or this aspect.
Yeah, absolutely. Well, currently, no, there isn't. But what we do have is there are various different angles of providers, different routes of referral from different providers that we get in ENT. So one big route of provider is audiologists in the community. So places like Specsavers, Boots, for example, who will do hearing screening on patients and provide hearing aids. Now, if any of them see an abnormal tympanic membrane, they will refer them into ENT. So we get quite a number of simple retraction pockets like this that are well before patients get to cholesteatoma that are referred in through those routes. But generally speaking, it's all about education. So if we can educate yourselves, but educate GPs and primary care to know what to look out for, then we can get those earlier referrals. And one of the problems with retraction pockets is they're sometimes asymptomatic until they start to collect skin cells, and then they get infected, and you get the early stage of cholesteatoma. But if you find it very early and it is discharging, but you can actually use suction in clinic and suck out the cholesteatoma out of the pocket, and you end up with a nice smooth pocket, then you can treat that pocket to prevent it from reforming cholesteatoma or recollecting skin as time goes by. So there are techniques, there are ways and pathways by which patients can get to us like that. But a lot of it depends on recognising that disease process in the first place. So primary care is really where we're targeting things at the moment, and there are guidelines. So with the British Society of Otology, we're writing guidelines for ear examination and when to refer patients and in which direction and how urgently to refer in certain situations.
Thank you. Thank you very much.
But the main thing really, the main bit of advice to give you guys is look at as many normal ears as you possibly can while you have the opportunity, so that then when you see an abnormal ear, you can immediately tell that there's something wrong with it. It doesn't matter that you won't necessarily know what it is that's wrong with it. If you can identify there's something abnormal, refer it in, and then the experts can make that decision about if there's anything that needs to be done.
I think, Harry, you've got your hand up.
Yeah, Professor Judd, thanks very much for that. Very interesting. You've obviously mentioned the cost and the actual procedural benefits of using endoscopes compared to previous methods. Are there any patient-reported improvements, be that hearing improvements, be that recovery times, in actually using these? I just sometimes wonder that, and I think this is the case in orthopedics quite a lot, that progress and new technology is used for the sake of it, not for the sake of it, but in terms of just progress, where actually the outcomes aren't necessarily improved.
Yeah, you're right. So when you say about hearing loss, so that's an interesting one, because the primary outcome for cholesteatoma surgery is to remove the disease and to leave the patient with a safe, dry ear. By safe, I mean that it's not going to form further cholesteatoma, less likely that you'll then get problems with central infection. But hearing loss or repairing of hearing loss and treating hearing loss is only a secondary outcome. when it comes to cholesteatoma. And often some patients end up with a worse hearing ear after the surgery, which we will then address at a later stage. So if you remember one of those images right at the beginning when I was showing you something about magnification, is that patient's incus had gone, and that was the disease process that had done that. But the incus was replaced by cholesteatoma. So the cholesteatoma itself was acting as an ossicle. When sound waves hit the tympanic membrane, the whole block of tissue vibrated and transmitted sound to the stapes. Now, as soon as you remove the middle part of that block away, you remove the cholesteatoma, you're left with a gap. So you get vibration of the tympanic membrane, the stapes doesn't vibrate. So that patient woke up with a worse hearing. They woke up with a significant conductive hearing loss. But the primary outcome, which was we'd remove the disease and we'd repair the area and made it safe and dry, was a positive. And then what we can do at a later stage, when we're happy cholesteatoma hasn't gone back, is we then go back in and repair that ossicular chain. But that makes it easy to repair because you've got an intact ear, you've got a normal, otherwise the ear is otherwise normal anatomically, so therefore it's much easier to repair it back to normal functioning ear. Whereas if you've got a mastoid cavity, it's much more difficult to do that. That's the first benefit. But the biggest benefit is because of the minimally invasive approach. So the two big problems and main complications and issues that patients have after they've had traditional ear surgery is a big wound. So the wound can get infected, it causes pain, you can get numbness along the side of the wound where you've cut through the small nerves that supply the skin, and other sort of wound issues, plus the cosmesis. So you end up with a big meatoplasty and a big scar behind your ear or in front of the ear if you do it through an anterior approach. Whereas, of course, with the endoscope, you get none of that. So you have no wound, external wound, so it's very unlikely to get infected. You don't have a big open meatus, so cosmetically it looks better. And of course, the recovery is much quicker because most of the recovery with surgery is pain due to the wound and dressings. You don't need any external dressings, bandaging or anything like that. So certainly from an outcome point of view, we're very cognizant of the fact that, for example, in certain fields of ENT, there has been much of this sort of orthopedic approach, whereas let's use this technology, not necessarily for the benefit of the patient. And I'll give you an example of that in a moment. But these things are improving all the time. And we are very aware of the fact that if we're going to progress, it has to be for the benefit of the patient. So the example I'm thinking about is robotic surgery for thyroid disease. So you might be aware of the fact that we use robots a lot for thyroid surgery now. Now, the reason for that is it is technically, it's more challenging. So from the surgical perspective, it's quite good fun using a robot, surgical robot. You can use all the new technology. But from a point of view of the patient, the only real benefit is they don't have a scar on their neck. So in certain parts of the world, it's culturally unacceptable to have a scar on the neck. But if you see a good thyroid operation and you look at the patients, that you won't necessarily know they've had surgery because the wounds are so small and so neat and heal so well. So my argument to that is, why are we altering the technique to remove what is essentially a very cosmetically pleasing scar for the sake of that small scar and an approach where you have huge amounts of morbidity? So the original robotic approaches for thyroid surgery was through the axilla. And it involves an enormous cut that goes from here to here. You lift up a lot of tissue and you basically tunnel under the skin to get up to the thyroid gland. And there have been complications of patients who can no longer use their arm. They have a brachial plexus palsy. You can have patients who have problems with infection, wound dehiscence, problems with their muscles not working properly, and pain long term, all to avoid essentially a small scar, which is minimal. But I'm pleased to say that now most robotic surgery is actually done using a better approach. For example, through the gum and tunneling down underneath the neck that way. So there are better approaches, and there's even intraoral approaches. So although technology is great, and I completely understand Harry, your comment that sometimes we use technology not necessarily for a better outcome, but just because we fancy using it. But I think if any of you do start to innovate when you become consultants, the important thing is to always keep in mind, why am I doing this? Is this for the benefit of me or the benefit of the patient? And it should always be the benefit of the patient, of course.
Really interesting. Thank you very much.
So, Professor Judd, I've got some that ties into what Harry's mentioned, but also what Fennell and the others mentioned. The first one was in relation to using, I think you talked about the GPs and having more training and that involved in there. I was wondering if is it more cost effective in terms of using an endoscope and say in primary care, or is there a facility to be able to use that? Because I've tried using otoscopes in care and it is hard getting in and moving around and trying to see all the attics. So is there something that can be useful in that sense to try and get that done, and then you get a better view and you have improve in terms of diagnostics for those?
Yeah, absolutely. And again, that's improving all the time. So I talked about Boots and Specsavers and some of the high street providers. A lot of them use otoscopic imaging now. So what they'll have is they have small otoscopes attached to cameras where they can take photographs, a bit like they do with the retina. And they can take a photograph of the tympanic membrane and email it to the local hospital for us to look at, to say, yes, this is an abnormal eardrum, or no, this isn't an abnormal eardrum. And that's happening more and more. Very, very similar to the fast track retinal images that they take and they can send to the ophthalmologist to view. And as time goes by, we're expecting this will be more and more widespread, and we'll get that in primary care as well, which we're hoping we will. And there are also attachments you can get for your iPhone. So there are very small endoscopes you can buy fairly cheaply that attach to a piece that clips onto your iPhone on the iPhone camera, including iPhone apps, which you can then place into the ear, and it's essentially an otoscope on your phone. And you get much clearer imaging. I've even had patients that have come to me that have bought one online and taken pictures of their earwax to show me, which, as you can imagine, is fascinating.
I guess it gives you a clear picture what to expect
It
as soon as
does,
you start
yeah,
looking
absolutely,
down.
yeah.
And then just in terms of outcomes, I know you mentioned, Harry, that hearing is the secondary outcome. And during the videos that you showed, it looked like with the tragus cartilage, putting that on there and trying to form that kind of ossicle chain across from there. How does that get anchored down in terms of forming that chain? Is it just glue, adhesive, and trying to put in place?
No, so it's surface tension. So these areas are tiny, and as you could see when I was placing that graft in, it sticks to your instruments, and there's nothing there that's sticking it to the instrument apart from a bit of surface tension, because there's a bit of fluid there. It's a wet instrument. So when you place all the grafts in position, you just think, and I sometimes see this with some of the nursing staff and the students in theatre. You think, I'm just leaving it there balanced. Is it as soon as the patient gets up, it's all going to fall apart? But it doesn't. It all sticks down, and it sticks down with surface tension, and you get a bit of bleeding, and the blood sticks it down nicely because of course it's quite sticky blood if you've ever got any on your hands, and the fibrin all sticks it down quite nicely. Plus, we put dressings in that will slowly dissolve away over the first few weeks, and that just holds it all in place as well.
Okay.
We don't want to glue it all down, because if you can imagine, if you're putting glue into the middle ear and it spills and starts sticking around the stapes, and you glue the stapes rigid, you get an even worse hearing outcome theoretically. So.
No, that's true. I was just looking at the video, I'm thinking how when they get upright, things are just gonna start
why does it
moving
not all
around,
fall apart?
but no, that's actually pretty interesting. And I know you mentioned the one-hand technique, but is there any two-hand techniques they're looking at in terms of endoscopic surgery, or is that still going to be primarily one-handed?
No, so when we do the national courses, that's a question I get asked quite a lot, is why don't you have like a robotic arm that can hold the endoscope, for example, or an endoscope holder? But then, of course, that defeats the whole point. So when we're trainees and when you're training, and this is why endoscopic ear surgery is now beginning to take off more, because we're teaching the technique to trainees, is when you're training, you as I say, you pick up little tips from other consultants that you've worked for, but you also learn the whole remit of ENT. You learn all the different subspecialties, and one of those subspecialties is endoscopic sinus surgery. So that's operating on the sinuses using an endoscope in the nose. And pretty much most, if not, apart from probably rhinoplasty, pretty much most nasal surgery and sinus surgery now is done with endoscopes. But that's not always been like that. So 30, 40 years ago, it was done with the microscope. And you would put a speculum in the nose, you would open the speculum up, so stretch everything out of the way, push the septum across the other side, and then get your microscope in and operate up the nose that way using the light from the microscope. Now, if I was to get that out in theatre now to do an endoscopic sinus case, people would say, what the hell are you doing? Because it's so archaic. But back then, when the individuals were originally starting to use the endoscope for sinus surgery, the old school surgeons were saying, what are you doing? That's ridiculous. Why do you want to operate with one hand? You know, were you making it more difficult for yourself? So as time's gone by, because we know that's significantly more benefit to the patients, minimally invasive, you get a better view, you can get better outcomes long term. If you went back to the old-fashioned way of doing it, people would think it's a very odd thing to do. So things do progress, and when you're learning sinus surgery, you learn that one-handed technique because that's exactly how you do it. And the reason we don't use a camera holder and two hands for sinus surgery is the whole point is you want to be able to keep moving around and looking at different areas that you're operating on, pulling the camera out so you get a wider view, putting the camera in again so you can focus in. And then you've got clear views of exactly what's going on in all the anatomical areas. If you've got a fixed camera, you can only see what you're doing in that fixed area. You can't go in and out much more easily. So from a training perspective, it's much easier to train trainees to do endoscopic ear surgery because they have those single-handed skills from learning endoscopic sinus surgery. If I was to go to Nottingham and see some of my old colleagues and say, why don't you start doing endoscopic ear surgery? They wouldn't want to because they've never really picked up an endoscope for 20 years. So teaching them how to do something single-handed now when they've been doing 20 or 30 years with two hands isn't going to work. But training new up-and-coming consultants as they go through is the exact way to do these things if you're bringing in new techniques. And it's not as difficult as it looks. It isn't. It's with practice. It's you can do it.
No, I appreciate that. Thank you very much, Mr. Judd.
Now, I did just remind myself about trying to show you that video of the. I
don't think there's any other questions on there, so I think we'll work.
Any other questions while I'm looking for this picture?
In the meantime, not sure if the chat's enabled for everyone, but we put a link in there for feedback on the talk today if you've got some time. If not, I can try and share a QR code for it, but I think it should be available. Harry, can you see the chat?
Just going to get that video for you.
Chat's all visible, Michael.
I think sometimes it works for us because we're on a uni account, but it doesn't always work for externals. So,
right, I'm going to try and show you this video.
Can everyone else see the chat?
No, I don't think we can.
give me 1 second. I'm going to show a QR code and then you can just scan that.
Okay, so I'm going to try and, if I can do it, you have to tell me if you can see this or not. Can you see this video on the screen?
Yep, I can see that.
So if you can see right in the very center of the screen, you can see those blood vessels. I'll try and play that again. You see individual red blood cells floating through those blood vessels. And again. Right in the very center. It looks like a little motorway. You've got all the red blood vessels and within them you can see little red dots floating along, and they're your individual red blood cells. So that just shows you the level of magnification you can get with the endoscope. Right in the very centre of the screen, you see it. Did you all see that okay?
I think I can see a bit of it.
Yeah, I'll play it again a few times. Very short video. So I've got an extremely good anaesthetist who always gives me an almost bloodless field. So I always like to show him this to show that the patient is still alive. Well, I hope that's been useful.
Thank you very much, Professor Judd. I really appreciate it. It was very useful, very interesting. So thank you very much for your time this evening. I'll put the QR code to try and get to the form if anyone wants to scan that in the meantime. And I'll stop recording as well. I don't think there's any other questions at the moment either. So
Thank you, Professor Judd.